Good day. Today's presentation will be presented by the Neurophysiology Group 1, which consists of Bronwyn-Lee Brew, Nicole Erasmus, and Nonhlanhla Shemaine Ngwenya. So right from the start, we want to give our viewers a hint about the disease. The hint is a riddle which you need to solve, and please keep it in mind throughout the presentation. So your riddle is, Miller went fishing. What is his syndrome? Do you know? Let's find out. Okay, so today's case presentation is about a 23-year-old Asian male patient that was referred to the intensive care unit by a general practitioner. The patient presented was an epileptic patient with a VP shunt that has had his routine checkups a week prior. The patient seemed too good and well with no signs or symptoms. However, an MRI scan was done which told a different story entirely, showing multiple cranial abnormalities. A few days later, the patient's condition changed dramatically. The patient now presented with total blindness. He can only see shadows, unable to see anything around him. As the days went on, the patient's condition worsened. He was then unable to walk, presenting with left-sided facial weakness as well as paresthesia. So, with the history, since the patient was a known epileptic, he was referred to the neurophysiology department with a query of possible subclinical status epilepticus. So with status epilepticus, this is a condition where a patient has a seizure lasting longer than 5 minutes or having more than one seizure within 5 minutes without returning to a normal level of consciousness. This includes in the patient's history is a congenital hydrocephalus, which was now arrested due to a shunt being inserted at the age of 6 years old. The shunt had migrated, however, the family declined to have it removed. The patient was found to have flaccid quadriparesia and is currently presenting with new onset seizures. There is no known family history of any neurological disorders. When a physical examination was done on the patient, the following was presented: ataxia, which is the abnormal muscle coordination; ophthalmoplegia, which is paralysis of the eye muscle. He had areflexia, which is the absence of tendon responses. He had generalized muscle weakness as well as respiratory failure was seen. And here the patient also experienced less severe symptoms such as diarrhea, he had a cold, he had a headache and a fever. So just a hint that you need to keep in mind, all the symptoms are related to a viral or bacterial infection. So a variety of tests was done on this patient. This include scans, your normal CT and MRI, nerve conduction studies, which measures how fast an electrical impulse will move through a patient's nerves or muscles, brainstem auditory evoked potential, also known as a BAEP, which is an evoked potential that is caused by stimulus to test the response of the auditory canal. This is very important to remember that this is not a hearing test. We test the nerves that help you hear. An electroencephalogram, also known as an EEG, which is a recording of the brain activity. A visual evoked potential, an evoked potential caused by a visual stimulus to test the visual response. Again, you need to remember that this is not a visual test to test the patient's vision. We test actually the nerves that help you see. And then lastly, there was a transcranial Doppler study done And this is also known as a TCD, where we look at the blood flow of the brain. So on this page, we look at the patient scans. On the right hand side, you can see the MRI and CT scans that was performed. So with these tests, there was a query on brainstem dysfunction. On the scans, it was discovered that the patient had a 7th cranial nerve palsy. For you that don't know, this is the facial nerve. He had hypertension, which is high blood pressure, tachycardia, and ascending paralysis. The brain MRI, as well as the CT scan, stated that the patient had age-inappropriate cerebral atrophy with the tip of the shunt in the brain mass, and also a ruptured anterior communication artery of aneurysm. So with this, they ordered a TCD to confirm the suspicion of the VP shunt. When a TCD is formed, you use a machine that uses a specific probe that we put gel on, that you put on the side of your head, just here at your temporals, where you have nice windows, where we make use of the circus of Willis. We all know the circus of Willis. It explains the blood flow in your brain. With a TCD, we look at main arteries. The main arteries we look at is your anterior cerebral artery, known as your ACA, your middle cerebral artery, which is known as your MCA, your posterior cerebral artery, known as your PCA, which is all in your head, and then you have your internal carotid artery, your ACA, which is here on the side of your neck. These are your main ones we look at. When the TCD was performed, the TCD was abnormal, which confirmed the suspicion of a ruptured anterior communication artery.
We did a nerve conduction study on the patient. We tested both upper limbs and lower limbs. We also tested both sensory and motor responses. The sensory responses all showed a normal intact response, which suggests a pathology proximal to the dorsal root ganglion. When we tested the lower limbs, we saw decreased amplitude in the peripheral nerve, which shows a degree of axonal injury. An EMG test was done on the patient as well, which showed an increased insertional activity with scattered fasciculations. This suggests a demyelination disorder. There were no recurrent muscle unit potentials seen. The clinical features suggest an acute inflammatory demyelinating polyneuropathy in the patient. In this slide, we see examples of the EMG in which there are no muscle unit potentials and scattered fasciculations.
So, with the BAEP that was performed, there is multiple ways you can do this. We use a 3-channel short latency BAEP that was done at 80 decibels normal hearing level. We use broadband clicks. We use broadband clicks in one ear. You use a masking noise in the other ear, so you can test one ear at a time. You do it bilaterally. You first do one ear and then you swap and you do it the other ear. It's very important to know that when you do this test, you need to incorporate noises in your environment. So a minimum of 2,000 responses were averaged and 2 replicate responses for each rarefaction, condensating, and alternating polarities. It's very important that you do all 3 polarities, where the sound waves is moving to the ear, away from the ear, and that you can actually see what's going on. And you do this on contralateral sides. So as seen on your right hand side, all peaks and predominant cochlear microphonic responses were identifiable bilaterally, which means on both sides of the ears. Absolute latencies of peak 1, 3, and 5, which is your most important ones, as well as your interpeak latencies 1 to 3, 3 to 5, and 1 to 5 were measured for rarefaction responses bilaterally. Do you know what I am? You maybe want a hint? Here it is. All peak and interpeak latencies were normal and comparable with the BAEP.
Due to the complexity of the patient case that was presented to us, we decided to run multiple neurodiagnostic tests on the patient, which include an electroencephalogram, which was done or performed to investigate the patient's electrical brain activity due to his very frequent seizures. He had multiple seizures in the ward, which resulted in the doctors deciding that the patient should be moved to ICU because they were suspecting that the patient is in status epilepticus. So 2 out of the 3 EEG recordings that we did on the patient were encephalopathic, and the last one showed multiple seizure discharges. So when we looked at all 3 EEGs that were performed, as you can see, showed highly asymmetric left hemispheric diffuse 5 to 6 Hz theta semirhythmic activity with low amplitude 2 Hz delta activity, where when we looked at the right hemisphere had a background that consisted of 0.5 to 1 Hz periods of sharp and slow wave discharges. And when we looked at the several seizure discharges, we noticed that they were associated with mouth movements or jaw movements. So a VEP was performed on the patient because our patient presented with blindness in both eyes, which then led to the complete closure of his left eye and impaired left eye movements. So this test is a test that provides quantitative measures of the visual system as a whole. So the functions that we measure include things such as the optic nerve through the optic chiasm and the tracts, which then project to the visual cortex. We were worried because due to his shunt, the shunt can move and then damage the optic chiasm, which plays a major role in a person's vision. Hence, we had to perform a VEP to investigate further to see if there was anything wrong with any part of the optic tract.
So, when we look at the pattern of the pathology, multiple tests was performed and was done over multiple days. So, with the blood work, I went and I took out the ones that are most reliable to this case study. So when we look at the white blood cell count, which was 13.46, it was high. This gives you an indication that there is an infection. So the hemoglobin was 17.7. So the hemoglobin is a protein in your red blood cells that carry oxygen to your body's organs and tissue and transports carbon dioxide from your organs and tissue back to your lungs. This was high, it was 17.7. When we look at your platelets was 379. His platelet count was normal, but this is a good indication because if your platelets are too low, you have a higher chance of bleeding from just a small cut. Your platelets is there to help you from stop bleeding. When we look at his erythrocyte sedimentation rate, yes, he is ESR, it was 10. This measures your red blood cells. This reveals if there's any inflammatory activity in your body, which by his was high. His urine and electrolytes was normal. His calcium was totally normal. His liver function was normal, but his procalcitonin. So with his procalcitonins, high levels is a sign of a serious bacterial infection, whereby his was normal. Repeat, normal. And then his sodium valproate, which is his medication for his seizures, was in normal range. It also gave us indication that he has no known allergies.
When we look at all the tests that conducted and the conclusions, we can come up with a diagnosis for the patient. The nerve conduction study was done, which showed fasciculations and suggests a demyelinating disorder. This, along with the clinical features that the patient showed, suggests an acute inflammatory demyelinating polyneuropathy. The BAEP was done, which showed a normal short-term latency. However, a clinical correlation is advised with this assessment. In the EEG, the findings were abnormal, which indicated a severe right hemispheric nonspecific epileptic dysfunction. This, however, may not be seen with clinical activity. A VEP was done and the findings were normal. This is due to the fact that the patient had loss of sight. However, it may only be temporary. When looking at these different findings from the tests, other possible diagnoses could be kidney failure or diabetes seen in patients. Determining that the patient met all of the requirements for Miller Fischer syndrome. Miller Fischer syndrome is a secondary condition to a bacterial or a viral infection. In this case, it could be from the shunt that the patient had that was going septic. The symptoms above that the patient showed do correlate with this finding. So Miller Fischer syndrome is a rare disease which affects the nerves. It is also a variant of Guillain-Barré syndrome, which is commonly seen now with COVID-19. It is an anti-GQ-big-G antibody syndrome and shows symptoms which include weakness that's seen in the face and muscles of the throat, which affect swallowing. In the case of our patient, it is seen in the limbs, and it's also seen patients suffer with respiratory failure. MFS affects both adults and children and is seen in patients several days after a bacterial or viral infection, which we believe our patient had from the shunt. MFS is a rare condition which only affects about 500,000 people each year. Miller Fischer syndrome is also an autoimmune disease and is described by the immune system attacking the nerves in the body, especially the peripheral nervous system. However, we are unsure of why this illness happens or why the antibodies attack the nerve in the first place. Scientists are still struggling to find out the answers for these questions that we have. When we look at diagnostic integration, we look at the signs and symptoms that the patient presented with and the diagnostics tests we did based on those symptoms. The patient first presented in the physical examination with ataxia, which is an abnormal muscle coordination, as well as aplexia, which is absence of tendons response, and just a generalized weakness as well as respiratory failure. Because of these symptoms, we did a nerve conduction study on the patient, and we found a left-sided flaccid weakness as well as paralysis in the patient. The patient presented with paralysis of the eye muscle. We did a VEP test on the patient, which came out normal. This is because it's only a temporary problem with this type of disease. The patient also experienced less severe symptoms such as diarrhea, headache, and a fever, which is generally seen with a bacterial or viral infection.
So Miller Fischer syndrome is a very, very, very rare form of Guillain-Barré syndrome. Guillain-Barré is very complex because it's an umbrella term for many other polyneuropathies such as AIDP, CIDP, and so much more. So we can describe this as a neurological condition that causes mild to severe muscle weakness, and it is caused by the immune system's reaction or an attack to certain proteins which are within the nerves, which are very essential for things such as movement, sensation, function, and so much more. So what happens is that this condition occurs after an infection, especially infections like infections of the airway, such as influenza, or infections of the digestive system, such as gastroenteritis. So the body confuses the nerves with the bacteria or the virus that is within the proteins, which leads to the body or the immune system attacking that intruder, which is then the nerves in this case, because they are like confused, and which leads to the nerves being damaged in the process. Hence, patients with Miller Fischer syndrome experience things such as tingling and numbness in the hands and the feet. There's pain in the back and the legs and the arms. There are eye problems, loss of coordination, and so much more. It's very complex and confusing in nerve conduction studies because it is so difficult to differentiate between a primary axonal loss lesion and a primary demyelinating lesion. So when neurophysiologists and neurologists come across patients such as these ones, they need to go through everything that they do with a fine-tooth comb so that there is no misdiagnosis, because it is very, very dangerous for us to make decisions based on assumptions without being thoroughly sure what is happening. So when we look at this, how it develops and how it progresses, we know that once it has been identified through various tests that are run or investigative tests that are conducted, it takes about 6 to 12 months for a patient to fully recover, but it may take as long as 3 years depending on the severity of the syndrome.
As previously mentioned, Miller Fischer syndrome is triggered by a viral or bacterial infection. However, the symptoms will only occur in a patient about a week to 2 weeks after the infection has already occurred. The occurrence of this is by an IgG anti-GQ1E antibody. The symptoms that start are a prickling feeling in the hands and in the feet, or pins and needles sensation. This will then progress to weakness in the legs and will eventually spread to the upper body. Following the weakness in the legs, the patient will then further go into unsteady walking and the inability to climb stairs. Patients will then start to lose coordination of their muscles. The patients also tend to show difficulty in facial movements. As the disease progresses, the patient will struggle to chew and then will progress to a complete inability of swallowing. When we're looking at the patient's eyes, they will start to experience double vision at first, which will then progress to complete blindness. It can be treated, however, if it is addressed early enough. The progressions of the symptoms occur as the nervous system is attacked by its antibodies, which causes a demyelination in the nervous system. If it is caught early enough, the treatment is very effective. Demyelinated axons will have a chance to regenerate, which in turn means that the symptoms will start to dissipate. However, if the patient is not diagnosed early enough, the demyelination of the nerves could become permanent, making the symptoms chronic. Symptoms such as blurry vision will then become blindness. The inability to walk means that a patient will end up in a wheelchair, and the struggling of swallowing could eventually cause the patient to become dead from this disease.
As mentioned before, Miller Fischer syndrome is caused by bacterial or viral infections such as flu, gastroenteritis, and so much more, where the symptoms start to appear 1 to 2 weeks after the infection. So when we look at the epidemiology, worldwide incidence is 1 to 2 in every 1 million people. So that's how rare it is. It is seen more in women than in men and has a mean age group of 43.6 years. There are various ways that a patient can be treated as far as Miller Fischer syndrome is concerned, both pharmacological and non-pharmacological. So pharmacological, we look at pain control such as opioids and corticosteroids. When we look at a non-pharmacological aspect of things, we look at respiratory support, immunotherapy, immunoglobulin therapy, and plasmapheresis.
The patient was treated in hospital for Miller Fischer syndrome. After the treatment plan was finished in hospital, they were then given a follow-up plan to do at home. The patient was booked for another neurological visit within 6 months. They were to continue on AED and titrate as per the discharge medication that was given. The patient was scheduled for tracheostomy and either continuous suction for the tracheostomy. They were to continue pressure care and Clexane. The patient was asked to see a physio and rehabilitation for the respiratory tract, and the family of the patient was also counselled. When looking at Miller Fischer Syndrome, there is an average recovery from the disease will take about 8 to 12 weeks. Most people tend to recover fully within the 6-month period, and it is known that there is a less than 3% chance of having a recurrence of Miller Fischer syndrome.
This will be concluding our presentation. Thank you so much, and I hope this presentation intrigued all of you.